Alyssa, we get the opportunity to speak to so many interesting people on so many different topics. I'm really excited to share the conversation with today's guest, Bethany Youngholt, because she's really focused on this area that doesn't really get that much attention, at least that we see, which is this idea of multi-purpose prevention technology. And essentially, it's a twofer. You might get disease prevention and disease treatment. You might get family planning or reproductive planning and disease treatment or disease prevention. This idea of combining them, and she's spent, her career focused on that. Does this come up a lot when you're at medical conferences?
This actually does not come up at all. And I think it is a Herculean task to try to marry these two subjects together. But boy, would it make it easy for patients and for their providers to try to kill two birds with one stone.
What's interesting in this conversation is how complicated is it to put these things together? In many cases, the work that she's doing concentrates on really integrating two things that are now separately available. And we certainly know from consumer behavior, from a compliance perspective, you will get much better compliance if a person has to do one activity versus two, if they have to take one step versus two.
I couldn't agree more. And it's funny because in practice, I see some women are truly just laser focused towards contraception of some sort. And other people are laser focused towards prevention of STIs. And I don't really think that anybody thinks to put these two things together.
Oftentimes, I think we hear conversations that people don't think this could happen to them, or it couldn't be them, or disease is what happens to somebody else, or unplanned pregnancy is what happens to somebody else. What do you experience in the conversations you're having with your patients in your office?
Look, I can give you a couple of real hardcore examples. We've got the perimenopausal woman who thinks perhaps she can't get pregnant any longer, even though she's still menstruating and having regular sex. So that's a population that oftentimes needs education and product to assist with this issue. And STIs are not just for teenagers. In other words, we see women who are a little bit older, who are back in the dating world, or perhaps people who have more than one partner who do need to address the prevention of STIs. So these are broad demographics who really need options for both issues. Welcome to the Business of the V. Hello, friends and colleagues. I'm Dr. Alyssa Dweck.
And I'm Rachel Braun-Sherrill. Each week, we bring you the most fascinating investors, inventors, entrepreneurs, academics, and healthcare practitioners who are making things happen in women's sexual and reproductive health.
If you are a woman, know a woman, have a business, or care about your V health and wellness, fasten your seatbelts and listen in to another informative and inspiring episode.
We are so excited to have our guest today, Bethany Youngholt, PhD, who brings really decades of experience in addressing the complex issues in women's sexual and reproductive health, as well as health inequalities. Bethany founded CAMI Health, which is an organization dedicated to that exact thing, to advancing the health of women and girls worldwide, and has been a leader in a number of other initiatives. We're delighted to have you with us today. Welcome.
Thank you. I'm delighted to be here.
So you've been in this space as an advocate for a very long time, as a researcher. One of the things we're fascinated by is your initiative around multipurpose technologies, or MPTs. Can you describe what those are and what your initiative is focused on? Really, what is the engine that motivates you to be in this work?
Thank you. As background, I have a PhD in epidemiology, but before I started doing that work, I worked in sub-Saharan Africa with the Peace Corps and with the UN, and working with some of the first HIV intervention programs in refugee camps. And then subsequently, I started doing research on STI and HIV risk and prevention in the San Francisco Bay Area. And what really struck me as I was starting to do my PhD work, looking at risk for HIV and STIs and unintended pregnancy, deficiencies in women's health overall was how these areas are so siloed, how they were so siloed. So you have HIV prevention, STIs, and family planning, and the approaches for prevention and treatment, have been very hard to access for so many women, regardless of whether a woman lives in a refugee camp in Ethiopia or if she is just trying to get by doing her day-to-day work in Oakland, California. You think about, having to take time off of work to go to a clinic for HIV or STI treatment and care one day, and getting prevention for your family planning needs another day, taking off work. And, so it just seemed very didn't make sense why this was so diverse, and the approach is so siloed, if you will.
It's siloed in terms of the treatment options, and it also siloed in terms of actually getting the treatment, that you're not often counseled to get HIV prevention or STI treatment or prevention at the same time as you're working on family planning, whether it's trying to have a family or trying not to have a family.
Yeah, I should say that that's the way it was about 20 years ago. And when I started doing this work and became so impassioned, and I think a lot of it has changed, but there's still tons more work in that area.
I think this just falls so neatly into the category of women being multitaskers. You are absolutely trying to kill two birds with one stone, and two super important birds at that. I want to say that from general anecdotal experience, most women, whether they're, Gen Zers or perimenopausal women or menopausal women new to the dating world, they just have this attitude that it won't happen to me, whether it's an infection or pregnancy for that matter. It won't happen to me. That's for that person over there, or that person living in that situation, or maybe one of the other countries you're mentioning. How do you address that in the US, where you think that the education level and resources should be enough to manage this?
Great question. We've actually done research on that in the US, and I actually did a study when I was on the faculty at Berkeley where we were interviewing college age students and university students about, what do you see as your risk for HIV, STIs, unintended pregnancies that could help sort of inform the development of these multi-purpose prevention technologies, which would have single products that would combine these multiple indications. And spot on, so many women they did have the attitude that, this will happen to other people, not me. Not everyone for sure, but I think one of the things, education is key, but also, honestly, I think we need to do a better job at acknowledging that when people have sex, they're doing it for fun for the most part. And they're not always thinking about it as we need prevention for something bad, because we're actually having sex for something fun and enjoyable. So another angle, I think that's another way to message around these multi-purpose prevention technologies. I'm coming at it as a public health professional, but I think we also have to look at it from a human perspective too. Are there other ways we can package these or message around or combine these so that they're, we take into consideration the reality of, why people are often having sex in the first place.
So other than condoms, which seem like the most obvious multi-purpose product, what else is available really when you think about it?
Yeah, actually, condoms are currently the only available multi-purpose prevention technology. They've been around for 2,000 years, and so women need more options. And condoms, even the female condom is not women controlled. So there are now, since we launched the initiative for multi-purpose prevention technologies in 2009, this field builds upon decades of innovation in family planning, contraception, and HIV and STI prevention. So since the official launching of the MPT field, there has been some funding from the NIH and from other funders, slow but sure. And now there's a pipeline of over 24 MPTs in development. So I want to give some examples if I can. So think about the Nuva ring. So the intravaginal ring that women have been using for a long time that delivers a contraceptive hormone typically. Well, now there are some innovative advances that combine so that you can take the intravaginal ring and it'll deliver a contraceptive and an antiretroviral for HIV and even for herpes. Herpes is a huge problem globally. There's also there are films that are in development, patches, microwave patches, gels. So there are some gels, topical gels that provide non-hormonal contraceptives. That there's, some of these are actually already FDA approved, but they're also showing indication for prevention against chlamydia and gonorrhea and some other STIs. And for your listeners, gonorrhea, STIs are skyrocketing in the US right now and globally. And chlamydia is an example of an STI that is just running rampant. And what people don't often understand is that if these STIs are left untreated, they can lead to pelvic inflammatory disease and infertility and even death. Syphilis, congenital syphilis, is another STI that people thought was under control 10, 20 years ago, and it is skyrocketing. And a real tragedy is that we're seeing more and more cases of congenital syphilis. So that means if the pregnant woman does not get penicillin during pregnancy, then her child is very much at high risk for congenital syphilis.
So you mentioned a couple of things that I think are so important. One is that in people's minds, they're not putting these two together. And one of the ideas behind the products that you're describing is it literally is, as the name suggests, multi-purpose prevention technology. So if you're already using a ring to prevent pregnancy, why might you not also use a ring for delivery of other ingredients? I think that's a mind shift. Yeah. And this is going to sound like a crazy analogy, but I think of the toothpaste industry, which very few people probably ever compare to contraception, but every time they want to add a new benefit, they put it right in the same tube.
Yep.
So you have fluoride prevention, then you have whitening, then you have breath freshening, then you have plaque prevention. I feel like there's some analogies here from other categories. This idea that you get two for the price of one kind of thing. Yeah. So without any additional effort, you can be preventing against some of these things that maybe aren't top of mind for people. And certainly many people don't know the long-lasting health effects of what not treating some of these conditions result in. I did want to go back to something that you said earlier, which is you said the female condom isn't totally within her control. I wanted you to explain that.
Well, if you think about, the female condoms are fantastic for prevention. I want to just say that they're terrific if they're used consistently and correctly. Female condoms, there's, the challenge with that is that the male partner typically knows that it's there. And has to cooperate with it. There's evidence that, you can feel it. It sometimes can make a noise. And there's been a lot of effort to make condoms better and more user acceptable.
The female condoms have gotten a little bit better. They're lubricated now with, I think, silicone. They are less noisy. People used to complain that they sounded like you would put them in and then it was like opening a bag of M&Ms in the middle of a quiet movie theater, if any of us can ever remember that. So that was a big deterrent to their use. They're also super expensive compared to a male condom. So while they're female used, there are a lot of roadblocks in terms of them being super common.
And they have actually exactly all of that. And, there have been some efforts recently to make them more affordable. What we're really working towards is a pipeline of products, a sort of like a menu of products, because for every woman, no one's the same. For me, my needs have differed over my reproductive health life. If you're a woman, depending on where you live, your age, your needs change. And so from the contraceptive world, we also see that when women have more choice overall, the use of a contraceptive product increases. So, that's why I think it's so exciting to see the innovation that's now being supported for the MPT field. In addition to the examples I listed, there's some new promising approaches for injectable products. So there's been some promising results for those who are aware of the HIV field. So there have been some really promising results recently on long-acting injectables for HIV prevention. So combining those with a contraceptive could be really a tremendous benefit.
Here's today's hot flash. 1 in 5 people in the US have an STI. And what's even more shocking is that many of these people are unaware that they even have an infection. Almost half of new STIs were among people aged 15 to 24 in the US, and this is a staggering statistic. I understand combining, but what's the problem with just taking 2 separate, well-established treatments or preventative measures, so a condom and a medication, and just putting the 2 together and just packaging them so that they would be used together? So for example, I have heard of a kit that has the Plan B, morning after contraceptive tablets, packaged with a pregnancy test, which makes perfect sense, but you don't have to mix the 2 together. They just can be sold or bought together so that it just is, ease of use is really there. Have you considered that?
Absolutely. Yeah, that we call co-administered. Yeah, and there's actually some work underway right now that is looking at co-packaging oral contraceptives using the LNG, levonorgestrel hormone oral contraceptive pill with oral PrEP. So, there's some funding and some support that's looking at that as sort of the first step. So sort of looking at that, do women like it? Would that increase PrEP uptake for HIV prevention in women in the US and globally? One thing around that is HIV is still a problem for women in the US, but yet PrEP, pre-prophylactic, the pill that you can take to prevent ahead of time, is actually abysmally low for women. It's like 1% in women in the US. So could there be a way to co-administer PrEP, co-package it so that it could increase uptake? And, I want to go back, it's like for so many women who are at risk for unintended pregnancy, HIV, SDIs, they're multitasking all these other things in their lives. We also see that these populations, the hotspots for these risks are often in the same populations where people are dealing with all sorts of other things, social inequalities. Yeah, so I love your analogy, Rachel, to the toothpaste, because I think one of the things that gets at is that, you have toothpaste that's making your teeth white. We all want white teeth, but then it's like, oh, well, then there's this other fluoride in there that's going to make me not have cavities.
And the analogies stand in skincare as well. You don't have to moisturize and do sun protection separately. And there's a lot of this is around consumer trends and consumer behavior. I mean, it's clearly well known that asking people to change behavior takes a lot more time, money, and effort than asking them to continue to do the same thing and get multiple benefits. You said something a few minutes ago that I really wanted you to repeat and shout, which is when women have more options. Will you say that again? Because I think that statement was so important.
Yeah, there is data out there that shows from all over the world that when women have more choice, more options, are more empowered to take control of their lives around reproductive health and anything, then they adherence is greater. And we can see that regardless of the country that you're living in.
And that is so logical. And the reason
Yes.
I want to reinforce that is it says when we get to choose what works best for us, we make choices. And oh, by the way, we then implement those choices. So this idea of compliance and usage, you had said early on, these methods are only as effective as they are used appropriately.
Yeah.
I'm curious, Alyssa, when in your office, how often you see, people have a choice, they've made a choice, and the biggest issue around usage is compliance.
Yeah. So first, it seems to me that most contraceptive choices are women's choices other than condoms, but women can still choose for their partners to use a condom. As far as in my office, I feel like access is the biggest hindrance to using both of these, preventative measures. So contraception is now becoming much more available, particularly via telehealth. There are several companies and offerings online that people don't have to necessarily come to the doctor's office. Foundations like Planned Parenthood and whatnot are always available and pretty easy to access. STI prevention, not so much. And I think that is in part due to the fact that condoms are really what we have now, other than abstinence. And as far as PrEP, again, I think this comes down to what has been taught to people, which is that that's not going to happen to me as a woman. That's a gay man's disease. And so this is an education issue, at least in my practice, to let women know that actually HIV can affect men and women, and surely pregnant women, and that it's preventable, which is really important.
How far away are any of these options that are in development? You referred to 24. How far away are any of them from being available in the marketplace? And will they all be RX, or will some be available over the counter or available without a prescription?
The combination of oral PrEP and the oral contraceptive pill, those are two products that are being combined that are already FDA approved. And so the hope is that that's going to be introduced into the market in the next couple of years in sub-Saharan Africa. So that's where it's first going to be introduced. There are some other, I'll just step back and say the majority of these products are in early stages of development. There are some that are in later stages. There are some non-hormonal contraceptives, gels that are showing some real promise for STI prevention. Those are what I consider sort of a low-hanging fruit. One of the things it's another early stage I didn't mention, but there's some approaches that are being looked at for 3D, using 3D imagery for developing these products. And I wanted to bring that up because that could be, they could be produced fast and quicker. But one of the challenges that I really see in this field is that there is so much innovation. The NIH, USAID, and now a growing number of other funders, small growing number of funders, there are funding this work, but a lot of these products get they move so far, then they rely on another government grant. And so the sustainability of the funding to keep these researchers, their innovation moving through the pipeline, it's always facing these hurdles. So there needs to be new funding mechanism, new types of maybe VC money, social capital money. There are some global health impact investors that are now starting to invest.
Is this in part because the studies themselves to bring these products to development are just slow and inefficient, or is it that they just require so much time and effort?
I think one of the challenges is that big pharma is not at this point investing in this field. Big pharma is, they used to be funding a lot in women's health and contraception, and for the past 20 or so years, they've backed off. So, frankly, that's a big problem. So there isn't that, that pipeline of money coming in to fund the pipeline of innovation. The research that's going on is really exciting, and it's just a matter of how the majority of the funding is coming from the U.S. government at this point. And so sort of there are, different constraints and how that works.
Well, again, I look to the education as being the backbone of your mission.
Yes.
There is some information that some of the hormonal IUDs may thicken up cervical mucus enough, just enough to help to prevent certain STDs, but not enough to fulfill the criteria that you're speaking of. We also do multi-purpose birth control pills, and not that this has much to do with STDs and prevention in that regard, but we often cite the benefits of lowering the risk of uterus cancer and lowering the risk of ovarian cancer. So I think if education frames one product as a multi-purpose product, it goes a long way.
So we really call the work that we do is a sort of a learning network where we bring together experts from across disciplines and clinicians are so key to that. And just thinking about what are some new innovative ways that we can educate patients and also bring in new types of investors into this field.
For the people who are interested in learning more about, as you describe it, this learning network about multi-purpose prevention technologies and learning more about the products that are in development, where would you direct them to go? What resources are available if they want to become part of this conversation?
Yeah, so we have the initiative for multi-purpose prevention technologies is we have an online hub. So we have, we track the different products in the pipeline. So I'll just say the website is www.theimpt.org. And so, if people get onto that website, you can have access to blogs, webinars, depending on sort of the type of information you want. There's lots of, peer-reviewed literature. And then we also are tracking the database.
Wonderful. Thank you so much. This is fascinating and hopefully a lot more information to come.
Thank you for being with us today and for all the work you're doing. And as you know, we are very, very focused on creating conversations around sexual and reproductive health so that women understand, and their partners and people identify as women, what their options are.
Thank you so much for inviting me.
Don't forget, subscribe to our podcast at businessofthev.com for the latest trends and trendsetters in women's health and business.